So let's just go. Okay, so today we'll continue our Nclex review with thyroid disorders. And so this is a interesting topic, and I have chosen the thyroid as the prototype for the endocrine problems because it's much more common. So we cannot talk about diseases of the thyroid without talking about the thyroid gland. So the thyroid gland is a butterfly-shaped organ, and it's located in the base of your neck. So what is its function? Well, it releases hormones that actually controls metabolism. That is how you would use energy. And the thyroid hormones regulate vital body functions, including those that are listed over there: breathing, heart rate, central and peripheral nervous systems, body weight, muscle strength, menstrual cycles, body temperature, cholesterol levels, and others. So one of the important things that I wanted to underscore here too is that in children, the thyroid supports bone growth, brain development, and nervous system development. So in addition to all those that are listed over there. Now, so what are the hormones that the thyroid glands are responsible for releasing? Well, they're responsible for releasing thyroid hormone T3 and T4. T3 is triiodothyronine, and T4 is also known as thyroxine. And they're often collectively referred to as thyroid hormones. So once your thyroid releases T4, which is your thyroxine, the organs in the body will now transform it into T3 so that it can impact the cells and actually, therefore, influence metabolism. So those are the two major hormones that are released by the thyroid. But in addition to that, it also releases another hormone called calcitonin. And calcitonin is to help regulate calcium levels in the blood by decreasing it. So whenever we're looking at thyroid hormones, sometimes we just say T3 and T4. But remember that there's also another hormone, and it is going to be calcitonin. Again, the role of calcitonin is it helps to regulate calcium in your blood by decreasing it. So let's take a look at the effects of T3 and T4, the thyroid hormones. They essentially affect all cells in the body, actually. But the most important things are that they regulate the rate at which our body uses calories or energy. And therefore, it would affect our weight loss or weight gain. And this is going to be an important influence of these particular hormones. The other thing is they are responsible for slowing down or speeding up our heart rate. So they have an effect on the cardiovascular system. In addition to that, they also regulate body temperature. So all these are going to be very important because when we talk about the signs and symptoms of thyroid problems, you're going to have problems with your metabolic rate, your heart rate, as well as temperature. And in addition to that, it also influences the digestive tract by influencing peristaltic activity. And then, of course, muscle contraction, as well as skin and bone maintenance by controlling the rate at which the body replaces dying cells. And so those are the major functions of your T3 and T4. So how are these regulated? How are these thyroid hormones controlled? Well, the hypothalamus, right over here, actually produces thyroid-releasing hormone, or TRH. And it causes the pituitary gland, the anterior pituitary gland, to produce thyroid-stimulating hormone. And the thyroid stimulating hormone in turn prompts the thyroid gland to produce the thyroid hormones T3 and T4. So always think of the chain like hypothalamus produces TRH, pituitary gland produces the TSH or thyroid stimulating hormone, and the thyroid produces T3 and T4. So this hormone chain reaction is regulated by a feedback loop so that when the levels of T3 and T4 increase, they're going to prevent the release of TRH and TSH. And likewise, when T3 and T4 levels drop, the feedback loop starts again. So this allows your body to maintain a constant level of thyroid hormones in your body. Having talked about how it's regulated, let's now talk about the function tests that can detect abnormalities in the thyroid. So several blood tests can measure our thyroid levels and assess how well our thyroid gland is working. And these are going to be called the thyroid function tests. So what does it entail? Well, the first one is going to be total T4 or the thyroxine test. This is going to also include free T4, total T3, and free T3 as well as THS. So the TSH test is the recommended first-line test. So this right over here, this is the first one that we're going to have. If the results are abnormal, then the TSH should be repeated along with a free T4. So THS first, and then T4. So TSH concentrations may be abnormal also as a result of non-thyroidal conditions, because you remember that TSH is going to be influenced by this one thyroid releasing hormone. So if we have a problem over here, it is also going to affect this one right over here. So it doesn't necessarily mean to say that the thyroid is at fault. It could also mean the hypothalamus or the anterior pituitary gland is going to be a culprit as well. All right, so the other tests that we're going to have are your thyroid antibodies. And these tests are very important because they identify different types of autoimmune thyroid conditions. So we will find out two autoimmune disturbances related to thyroid later on in this presentation. And then thyroglobulin is another test, and this test is used to diagnose thyroiditis, or merely an inflammation of the thyroid. And this usually is going to also include the thyroxine binding and transporting thyroid hormones, which would reflect inflammation, and it could also reflect the presence of cancer. And radioactive iodine uptake. Now, because T4 contains iodine, the thyroid gland must pull a large amount of iodine from the bloodstream in order to make an appropriate amount of T4. So whenever we are going to see whether or not the thyroid gland is trying to absorb a lot of T4, we're going to give a iodine uptake. And the purpose of this is to determine how fast the thyroid gland is pulling this iodine. So a high RAU, or radioactive iodine uptake, is usually seen in hyperthyroidism. If the radioactive iodine uptake is slow, then that means to say that it is hypothyroidism. hypothyroidism. Okay, thyroid scans could also be done, and this is in order to determine whether or not there is going to be abnormalities in the thyroid gland itself. All right, so in hypothyroidism, these are the basic things that's going to happen. You will have a low T4, but a high TSH, okay? Because of the fact that there is going to be a decrease in T4, the thyroid stimulating hormone is going to have to be activated. So again, high TSH is going to be hypothyroidism. Low TSH is going to be hyperthyroidism. And this is usually something that confuses individuals because if you think about it, high TSH, you're thinking that it should be hyperthyroidism. No, it is the opposite, because if you remember, the purpose of the thyroid stimulating hormone is to stimulate the production of T4, as you could see over in this slide. So if you have a lot of TSH, that means to say that the thyroid gland is not acting, and therefore that is going to be a manifestation of hypothyroidism. So this is all that I want you to remember. As far as the high TSH levels are going to be hypothyroid, a low TSH level will be hyperthyroid, and high T4 will be hyperthyroid, and low T4 will be hypothyroid. Okay? All right. So there are several things that we can do actually in order to diagnose thyroid disease. But basically, this is the only one that I want you to remember, the T4 as well as the TSH. And this is going to be much more important than the other test because that would be more advanced. Okay? So in hypothyroid, your T4 is going to be decreased. In hyperthyroid, the T4 is increased. And the TSH is going to be the opposite. Okay, let's go to the first poll. Where's my poll? Okay. Okay, so the correct answers here are B, C, and E. The reason why letter A is incorrect is because they burn up calories. They don't store them. And letter D, it increases the body's temperature. Because you remember, when you increase metabolic activity, you're going to have two metabolic byproducts. One is going to be carbon dioxide, water, and heat production. And that is the reason why it would increase the body's temperature, not decrease the body's temperature. All right, so the disorders that are related to abnormal thyroid hormone levels are going to be either hypothyroidism, which is an underactive thyroid disease, and underneath this is going to be an autoimmune condition that causes hypothyroidism. Autoimmune disease is when the body starts attacking our own cells. And in this particular instance, it attacks the thyroid gland, and therefore it causes hypothyroidism. Now, the other one is hyperthyroidism, or an overactive thyroid. And the autoimmune disturbance that's related to hyperthyroidism is Graves' disease. So again, this is an autoimmune disorder. So Hashimoto's is going to be hypothyroidism. That's the autoimmune disturbance. And Graves' disease is the autoimmune disturbance that's going to be related to hyperthyroidism. Now, there could also be an inflammation of the thyroid gland, and that would be thyroiditis. And sometimes there might be development of some nodules or enlargement of the thyroid gland, or even thyroid cancer. So these are going to be the primary abnormalities related to thyroid hormones. Now, also remember, however, the pituitary gland or problems with the hypothalamus can also cause abnormal thyroid hormone levels because they help control the hormone levels in the body, as illustrated in this particular slide right here. So if I have a disease right of the hypothalamus or the anterior pituitary, it could also affect the thyroid glands. So let's now focus our discussion on hypothyroidism. So this is the thyroid gland's inability to produce enough thyroid hormones. And it has several causes, and it includes an autoimmune disturbance called Hashimoto's disease, or it could also be caused by postpartum situations, removal of the thyroid gland, or medications that kills or decreases the activity of the thyroid gland. Radiation treatment, for example, is one of them, as well as some iodine deficiency. And this is going to be something that is going to be sourced from the diet. Okay, so what are some of the medications? Well, let's go to the symptoms first. So what are the signs and symptoms of hypothyroidism? Well, think of slow, because the metabolic activity will be slow in these individuals. What's going to happen is that everything seems to be slow. So if I'm going to magnify the slide right over here, it would include thinning hair or hair loss, enlarged thyroid, a puffy face, dry and coarse skin, slow heartbeat, poor appetite, constipation, infertility, and carpal tunnel syndrome, cool extremities, and swelling of the limbs. And the thyroid gland does not produce enough thyroid hormone. And the other things that might occur is weight gain, poor memory, intolerance to cold, and feeling of tiredness. So why are they intolerant to cold? Because they're not producing enough heat. You remember that the thyroid hormones are responsible for metabolic activity. And so if there's a slowing down of metabolic activity, we're not going to produce heat. And that is why patients who are going to be hypothyroid are always going to be cold. Now, I must also add something over here, because it's not in the slide, that in infants, hypothyroidism can occur in infants, and it could also be manifested by excessive sleepiness in infants. And the other thing is that these infants are going to be predisposed to constipation because of the decrease in your peristaltic activity. And as the as the illness progresses, they could also develop an umbilical hernia and a protruding tongue. So this is going to be a common finding in infants: umbilical hernia and a protruding tongue. Now, this has been a select all that apply questions in Nclex. And so that's the reason why I came back here to add this information. Okay, so umbilical hernia, protruding tongue. I think you could deduce that constipation will be present because of the fact that there's going to be a decrease in the peristaltic activity of the patient. Okay, so what are the lab manifestations when there is hypothyroidism? So whenever it comes to lab values, you will be looking at the T3 and T4 as well as the THH. And of course, we are going to rely on the thyroid panel. So you're going to have a high TSH, and of course, you're going to have a low T4. And this is going to be the characteristic of primary hypothyroidism. But there's also going to be a variances, like for example, over here, primary hypothyroidism, secondary, and that would be a confusing thing if you take a look at that. So what I'd like for you to remember is that in hypothyroidism, it's just the T3, T4, which would be low, and the TSH would be high. Okay? So that's the laboratory manifestation of patients with hypothyroidism. Let's now look at the autoimmune disturbance of causing hypothyroidism, and this is what's called Hashimoto's disease. The main difference between Hashimoto's and hypothyroidism is the cause of each one of them. So Hashimoto happens to be an immune system disturbance, whereas hypothyroidism, primary hypothyroidism, is when your thyroid is underactive and not producing enough thyroid hormone. So Hashimoto's is actually the most common cause of hypothyroidism. And it is also known as lymphocytic thyroiditis, but it's better known from its name Hashimoto. This is a Japanese surgeon who described this particular form of hypothyroidism, and that is why it's more referred to as Hashimoto. Okay, so how do we know that a person has Hashimoto and not an underactive thyroid? Well, a diagnosis of Hashimoto is going to be made by positive blood tests or the presence of specific antibodies. So that is the way in which we identify whether or not this is going to be an autoimmune disturbance. And the antibody that is present in patients with an autoimmune disorder causing the hypothyroidism is going to be a presence of antithyroglobulin, antibodies. Okay, so that's the antibody that will be detected if you have Hashimoto's disease. So the presentation as well as the symptoms of patients with Hashimoto's are going to be the same as that of hypothyroidism, which includes your weight gain, your cold intolerance, constipation, dry skin. These individuals will be depressed as well as an enlarged thyroid gland. So that's Hashimoto's hypothyroidism. So what's the treatment for hypothyroidism? Well, the treatment would be to give, obviously, your, what do you call that, thyroid hormone. And your thyroid hormone could be your liothyronine or triiodothyronine or T3. And this usually is going to be given in once a day. It has a very short half-life, and therefore it's not going to be the treatment of choice. The treatment of choice is T4, and that's levothyroxine and thyroxine. So the reason why this is going to be the ideal treatment for this patient is because of the fact that it has a longer half-life. It's up to around 7 days. So usually this is taken once a day, okay? And when is it best to take the medication? Obviously, it's going to be best to take it early in the morning. And the action of this is it's going to convert T4 to T3. So what are the side effects? The side effects would be the same as hyperthyroidism, meaning to say that you will increase their thyroid hormone, so they might have nervousness, for example, anxiety, they might have tremor, they're going to have heat intolerance. So all the opposite symptoms that they have are going to be the side effects of this particular drug, so including arrhythmias. So T4 and T3 are given orally. As I said, T4 is better for long-term replacement. IV administration is only done during emergency, like in myxedema coma. And during pregnancy, a hypothyroid woman would require higher doses of the drug for obvious reasons. All right, so what are the nursing implications as far as hypothyroidism is concerned? Well, make sure that the patient is going to monitor their diet and their weight. And because of the constipation, you want to make sure that you encourage a high fiber diet, but also minding that the patient needs to prevent constipation, but also to promote weight loss. And then, of course, make sure that if the client is dry, to use moisturizers, and client education regarding the therapy. So what is it exactly that we have to teach them about these medications? So if the thyroid gland is not producing enough hormones, the patient will most likely going to be on these medications on a lifelong treatment. And so we also would like to tell them about the medication that they're giving, that they should take it on an empty stomach. Mm-hmm. And that usually is in the morning with a full glass of water before a meal, and it usually is 30 to 60 minutes before a meal. 30 to 60 minutes. before breakfast. We also want to monitor the fluid intake and as well as the side effects of levothyroxine overuse. So the side effects of levothyroxine is going to be the signs and symptoms of hyperthyroidism. So that would include, therefore, insomnia, tachycardia, heat intolerance, weight loss. And this means to say that the medication is working too well, and sometimes we might have to readjust their dose. Okay, let's go to the next. Very good. So the only one that's listed over here that's going to be appropriate is going to be letter C. All the other medications are going to be used for hyperthyroidism. So letter C is the correct response. All right. So there are other things that we also must remember whenever we are giving thyroid medications. And the first one is that it worsens glycemic control. So your Synthroid, if the patient has diabetes mellitus and they're taking Synthroid, for example, they might need higher doses of anti-diabetic drugs. So requires higher doses of diabetic drugs. All right, the other implication is that it increases the response to anticoagulation. It increases response to anticoagulation. So if it increases the response, what should be the dose of the anticoagulant? Should it be increased or should it be decreased? Should the anticoagulant be increased or decreased?
Decreased?
No, because you increase the response, so that means to say that requires less anticoagulants. Okay, so the dose has got to decrease. And the last one is in pregnancy. What is the implication of the use of these drugs in a person who's pregnant? There's an increased risk to both the mother and the fetus, but nonetheless, this is still going to be the one that has to be weighed very carefully by the obstetrician and the endocrinologist, because without the Synthroid or without the levothyroxine, the patient might go into crisis. And so you're damned if you do and you're damned if you don't. So they have to know that there is a risk for both them and the fetus by being pregnant. So what is the implication for this one? Well, the woman has got to be taught about this risk, and therefore they have to make a decision and be supported as far as that decision is concerned. Okay. All right. So, what are some of the other things that we need to make sure that we teach patients who are taking Synthroid or levothyroxine? Well, make sure that the patient does not stop it abruptly, because stopping it abruptly is going to cause a rebound, and therefore that has got to be avoided. And then, of course, we need to emphasize that this is a lifelong therapy. It means to say that it's not going to be only used for 6 months, it will be used forever. Okay, so let's go to the next poll. All right, you're all actually correct. It is letter C. Uh, with congenital hypothyroidism, which is a problem, there's going to be a condition at birth wherein they might have normal or the thyroxine levels are not really that bad. However, we have to realize that maternal thyroxine uh, crosses the placenta to the fetus, and therefore it supplies the fetus and neonate sufficient amounts of your thyroxine. So at birth, the hypothyroidism signs are commonly masked. They are not going to be identified. And so letter C is the correct response. Okay, very good. So letter A is the correct response. All the other ones will be signs and things that would be effectiveness of therapy for patients who have hyperthyroidism. Okay, so letter A is the correct response. So when there is a severe decrease in your thyroid hormones, then we have a life-threatening condition. And this is going to be what is known as myxedema crisis. Most patients do not become comatose, and therefore it used to be called myxedema coma. But because of this evidence that we have found that most patients do not become comatose, then the term myxedema coma has been erased or replaced with myxedema crisis. So myxedema crisis is a medical emergency. It requires immediate attention. And if the diagnosis is suspected, the patient has got to be brought to the ICU because of the high mortality rate on these patients. So they have to be continuously monitored, and the initial therapeutic intervention would be airway management as well as thyroid hormone replacement and supportive measures. So what are some of the causes or the factors that increases the incidence of this emergency, the severe hypothyroidism. Well, the patient might have taken drugs. And what are these drugs? That specifically predisposes individuals to having a myxedema crisis. Well, sedatives, narcotics, for obvious reasons, they're going to decrease, again, the metabolic activity, as well as anesthesia, and also lithium and amiodarone. So all those things are going to be the most common reasons why patients develop myxedema crisis. And sometimes stress, and when I say stress, what I mean by that is physiologic stress like infections, stroke, trauma, heart failure, maybe hypothermia, particularly during the winter, and also the patient forgetting to take their medications. These are some of the factors and the causes why there's going to be a severe hypothyroidism. So the key features for myxedema are altered mental status. They may become somnolent or lethargic. They might have defective thermoregulation, meaning to say that there's going to be severe hypothermia. The lower the temperature, actually, the worse the prognosis. And of course, with cold weather, the body temperature may drop sharply, and that is the reason why it usually develops during the winter months. And then, of course, on physical examination, you're going to see hypothermia, hypoventilation, hypotension, bradycardia, and delayed deep tendon reflexes. So all will be decreased. And I'm going to go to this one because it shows us that everything is going to be going down. So your temperature, your mental status, your blood pressure, your heart rate, your sodium, your oxygen, as well as your glucose, all are going to be decreased. And that is why this is recognized as an emergency. Okay. Now, in addition, if you take a look at their ECG, what do you notice about this ECG? See the height of the complexes? They are so small. And this is the characteristic of finding in patients with hypothyroidism, particularly when they are in crisis. All right. So it might include bradycardia as well as low voltage. This is what's known as low voltage. And sometimes they might have a flattened T wave. As you could see, you couldn't even see a T wave over here. It's very hard to see the T wave. And those are the electrocardiographic manifestations of a person with hypothyroidism and severe hypothyroidism, meaning myxedema crisis. So how do we treat these patients? We recognize that this particular situation is a medical emergency, and therefore early diagnosis and early treatment is going to be very important. And particularly the rapid administration of thyroid hormones and supportive measures are going to be important. So in looking at the therapeutic interventions, notice that we give IV liothyronine or L-thyroxine. So this is going to increase their thyroid hormones. And because of the decrease in glucose, we could give them steroids like hydrocortisone. And this usually is going to help in reversing the severe hypoglycemia in the patient. Now, the other thing is treatment of electrolyte imbalance. And usually we would give them normal saline particularly if they have hyponatremia. And in some cases, we might have to intubate the patient and connect them to a ventilator. And because pulmonary edema might also occur, furosemide can also be given as necessary. And of course, be the treatment for hypothermia. All right. So let me just emphasize something over here, because this is something that is going to be a common question in Nclex. We all know that in hypothyroid patients, they're going to be always cold, right? There is one contraindication. We should never use warming blankets on these patients. Why do we avoid warming blankets on these patients? Number one, they're predisposed to burns because they don't feel if it is too much. So you have to be careful that this patient is not going to be conscious about not using an electric blanket. And the other reason why we usually do not use an electric blanket or warming blankets is because it causes peripheral vasodilation. If you have peripheral vasodilation, you can therefore have hypotension and contribute more to cardiovascular collapse. So that's the reason why we are not going to use warming blankets or electric blankets. All right. Letter A is going to be the answer because it says at bedtime. What would happen if the patient takes it at bedtime? It actually is okay to take it at bedtime, but the reason we don't want it to do it at bedtime is for the fact that it will cause insomnia. So we always advise them to take it in the morning on an empty stomach, 30 to 60 minutes before they eat. Okay, so you are going to be tricked over here. The patient is in myxedema coma. We know that this is very important, but this is also the priority. You remember A, B, and C, airway, breathing, circulation. So this would be the priority, and letter A would be number 2. Okay? All right, letter A is going to be the correct response. Thyroid replacement is a lifelong maintenance therapy, and the medication is usually given every morning before they eat. Okay, so letter A is the correct response. Hmm. Okay, I somehow or another I put this in the wrong place. It should be on for the hyperthyroidism. And anyway, for patients who are pregnant, we usually start them on PTU. This is the only anti-thyroid medication that can be used during the first trimester of pregnancy. So would you please take a note of this? This is the only medication for the first trimester of pregnancy because it's safer for the fetus. And that is why it is reserved for use during the first trimester of pregnancy. And that's PTU. Okay, so now let's go to the opposite of hypothyroidism, and that is going to be hyperthyroidism. And again, over here, there's going to be an excessive release or discharge of thyroid hormone. And of course, it leads to an increase in metabolic rate. Now, there is another form of hyperthyroidism, and that is the one that is going to be the autoimmune disturbance, and that is what is known as Graves' disease. So this is the most common cause of hyperthyroidism. And actually, Graves' disease is very common, or more common, I should say, in women than it is in men. And again, the reason why they are having the hyperthyroidism is because of an autoimmune disturbance. And so the antibody that is going to be present in these individuals are going to be your thyroid stimulating immunoglobulin, or TSI. And so a positive TSI or a high TSI is going to be diagnostic of Graves' disease. So thyroid stimulating All right, so TSI or thyroid stimulating immunoglobulin is going to be present. All right. So basically, the signs and symptoms of Graves' disease are going to be the same as hyperthyroidism. However, there is going to be a unique sign that is only going to be present in patients with Graves' disease. And that is going to be your protruding eyeballs as well as goiter. So protruding eyeballs. So this is going to be the one that is different from the other causes of hyperthyroidism. Okay, so the symptoms of hyperthyroidism are going to include the following: weight loss, increased appetite, there's going to be an increase in body temperature, heat intolerance, sensitivity to heat. And so it's all the opposite of hypothyroidism, including tachycardia, palpitations, arrhythmias, hypertension, diarrhea, and anxiety and nervousness. So all those are going to be signs and symptoms of hyperthyroidism. So in Graves' disease, you have the other two symptoms that are going to be present, and that's going to be the enlargement of the thyroid gland or goiter and the exophthalmos or the bulging of the eyes. Okay, so those are the manifestations of hyperthyroidism. So the symptoms of Graves' disease, once again, are going to be similar to the patient with primary hyperthyroidism, but these are going to be the ones that are going to be different. Okay. Now, there's also going to be a red skin, usually on the shins, like, for example, on this slide right over here, we have dermopathy is what it's called. And then, of course, the bulging of the eyeballs right over here. And this is because of the weakening of the muscles of the eye as a result of an increase in thyroid hormones. That is the reason why they have Graves' ophthalmopathy or bulging of the eyes. So can you deduce, I know we haven't gone to nursing interventions, but anyway, if a patient has a bulging eyeball like this, they're going to be predisposed to drying of the eyes because they cannot close their lids sufficiently because of this bulging eyes. So the important intervention for patients with ophthalmopathy or bulging eyes is going to be to protect the cornea. And we're going to talk about the measures in order to prevent the deterioration or drying of the cornea. All right, there's also going to be nail symptoms. And the nail symptom for hyperthyroidism is spoon nails right here. As you could see, there is a spoon nail. I mean, it looks like a spoon. That is what's called koilonychia. The opposite of that in hypothyroidism is going to be brittle and nail splitting. So they usually have splitting of the nails, and it's going to be a thin nail in patients with hypothyroidism. Okay, so in hyperthyroidism, there's an increase in the rate and growth of the nail as compared to the nail bed, and this results in the separation of the nail from the nail bed, and that's why it causes this spoon-like shape of the nail. Okay, so I promised that we were going to talk about Graves' ophthalmopathy. We have to make sure that we treat these individuals in order to protect the cornea. So what are some of the interventions that we're going to have to use? The first one is making sure that we lubricate the eyes with eye drops. So people who have thyroid eye disease are not able to blink properly, and therefore this leads to dry as well as irritated eyes. And of course, because of the dryness, the tear glands will not produce, will produce less tears, I should say, which makes the eyes even drier. So whenever we're using lubricating eye drops, we have to make sure that we advise them that they should use preservative-free formulations. And this is going to reduce the irritation that might be present in things that have preservative. All right, the other thing is selenium. And what is the function of selenium and what is it? It's a nutrient. And this is going to be a nutrient that's important for normal thyroid production. And usually they have found out that supplementation with selenium is going to improve thyroid eye disease specifically. Third, they need to avoid secondhand smoke. Secondhand smoke causes inflammation of the cornea and therefore disrupts the balance of the eye's tearing mechanism. And therefore, that's also very important. Elevating the head. Just as you'd prop up a swollen ankle on a chair when it's inflamed, elevating the head can help ease the swelling that is associated with thyroid eye disease. And sometimes we might have to resort to taping the eyelids together. So sometimes we put gel right over here, and then we tape it together. So this is particularly important before the patient goes to sleep, because they are not going to obviously know when their eyes are getting very, very dry, and therefore taping it might help. And there's a device called Fresnel prisms. This is a film, it's a plastic film that sticks to the front of the eyeglasses. And these are helpful for people who develop diplopia or double vision as a result of thyroid eye disease. And then, of course, we always are going to emphasize that they have to use wrap-around sunglasses, not just ordinary sunglasses, because sunglasses will just cover this area right here. What you need is a wrap-around. It should also be here are the sunglasses. So even the sides are going to be darkened, okay? So wrap around sunglasses in order to decrease the exposure to sunlight, to wind, and to air, which could further irritate the eyes, obviously. All right, so the general nursing considerations for patients with hyperthyroidism are going to include, obviously, monitoring the vital signs as well as ECG, because the ECG might manifest arrhythmias. Well, we also are going to administer medications, and there are several medications that are going to be appropriate for patients with hyperthyroidism. And they include your anti-thyroid medications as well as beta blockers. And we'll talk more about specifically about these medications in a little bit. And then, because diarrhea is a problem, there's going to be a important assessment that you have to do, and that is to monitor their electrolytes. Because if you have diarrhea, obviously you're going to have electrolyte disturbances as well. And then radioactive precautions, thyroidectomy instructions, and monitoring for complications of thyroid storm is going to be important as well. So I reserve these three things: the medications, the radioactive iodine, and thyroidectomy last, because this is going to be the focus of where most of your Nclex questions are going to be. Yes, you got that correctly. Letter C is the correct response. It's Graves' disease. Okay, very good. So thyroidectomy is going to be one, and we're going to talk about that later on. And B, methimazole. Obviously, we're not going to give any more T4 because the patient has a lot of it, but we're going to treat it with radioactive iodine. Okay, so let's talk about the crisis that occurs when there's severe hyperthyroidism. And this is what's called thyroid storm. So just imagine storm is strong, okay, strong wind. So everything is going to be exaggerated. This is also referred to as thyrotoxic crisis. Similar to myxedema crisis, it's an acute, life-threatening state characterized by an increase in or excessive release of thyroid hormone. So this is going to be an emergency as well. And so the signs and symptoms of hyperthyroidism are going to be neurological, agitation, anxiety and delirium, psychosis, coma. And the cardiovascular are the most important ones because they're the most common that we're going to see. They might have severe tachycardia. They might go into congestive heart failure. They might go into hypotension and shock and death from cardiovascular collapse. So these are the findings. And like myxedema crisis, there's also going to be a reason why or what triggers the severe hyperthyroidism. So the first one is going to be trauma, myocardial infarction, and surgery. Now, when you actually manipulate the thyroid and you start holding them and massaging them, it releases a lot of thyroid hormones. And so that is why in surgery, sometimes when they do a thyroidectomy, because of the manipulation of the thyroid, it could cause actually severe hyperthyroidism. Infection is the most common cause, diabetic ketoacidosis, as well as hypoglycemia. And excess iodine exposure is going to be also one. And then, of course, this is obvious. If the patient is not taking their medications, then they're most likely to go into a crisis mode. So these are the symptoms, but again, these are the ones that are going to be very important. And because of the increase in thyroid hormones, remember that this patient is going to develop high fever. So there's going to be hyperpyrexia. So the fever could be very high, and it is actually common. And in fact, the patient is going to show signs of very high fever. And so that might include, for example, excessive sweating. And of course, your temperature might even register a temperature of 105, 106, and so on. So it is very, very common. And the other one is atrial fibrillation. In fact, this finding is very common. It is present in a third of the cases of patients who are going to be in this crisis mode. So how do we treat it? Well, similar to the treatment of patients with myxedema crisis, we're going to put them in the ICU and, of course, have supportive measures like IV fluids, oxygen, cooling, and the treatment of precipitating factors. But what are the drugs that we could give? Well, we could give them beta blockers to control the heart rate. So any medication that is going to end with all again is going to be an option for the treatment of these individuals. And then, of course, methimazole or propylthiouracil. And the purpose of PTU or propylthiouracil and methimazole is to decrease the production of thyroid hormone. And iodine is also given to inhibit thyroid hormone release and glucocorticoids in order to decrease the conversion of T4 to T3. Notice that glucocorticoids are both given in myxedema crisis as well as in as well as in thyroid storm. Okay. So these are the pharmacological management of patients with thyroid storm in the order in which we give them. So take a look at number one. Number one is going to be beta blockers. And you might be thinking, why is it that we don't give the antithyroid hormones first? Well, the reason for that is you remember that cardiovascular collapse is going to be a number one problem that is going to manifest itself, and therefore beta blockers are going to be the choice. Okay, so the number two are going to deal with your drugs that blocks the synthesis of thyroid hormone, and that includes your PTU and your methimazole. So PTU is actually the better of the two because it has a faster onset. And PTU is also preferred in pregnancy, as we said earlier. They have the same action. They block the synthesis of thyroid hormones. And then these are going to be the next one, the iodine or iodide and the steroids. And the reason why iodide is given is iodide inhibits the release of thyroid hormone that is stored. And steroids are going to decrease the conversion of T4 to T3. Okay, so what are the drugs for the management of patients with hyperthyroidism outside of thyroid storm? Well, it's going to be the same. Your thiamides, which are your propylthiouracil and methimazole, they inhibit hormone synthesis, as we have already talked about. And it could also include your Lugol solution, as well as your iodinated contrast media and other things such as radioactive iodine. And we'll talk more about radioactive iodine in a little bit. So before we do that, let's go ahead and answer this question. Okay, so the correct answer is letter B, a patient with diabetic ketoacidosis with mistaking methimazole. All right, let's go to another one. All right, I think you're getting it well. Letter D and letter E are the correct responses. So heart rate of 20 beats per minute. This would be for hypothyroidism. Intolerance to cold also would be hypothyroidism. This one, increase in temperature, an increase in heart rate, and an increase in respiratory rate would be something that we would see in patients who have thyroid storm. All right, here are the answers, A, B, and C. Okay, so why not letter D? Remember, they're hyperthyroid, they're intolerant to heat. So you don't want to keep the environment warm. Encourage frequent visitors. They're now going to be, what do you call that? Uh, you should provide rest periods because you want to reduce the metabolic demands of the patient, and therefore you would limit the visitors and conversation. So A, B, and C are the best responses. All right, so you remember that one of the manifestations of hyperthyroidism is going to be restlessness and insomnia. So if she says that I'm able to sleep and rest at night, then that means to say that it is working well. All right. All right, if you're giving an anti-thyroid medication, then it should cause bradycardia, not tachycardia. So letter B is totally incorrect. All right. So the correct answer here is letter A, granulocytosis and aplastic anemia. It depresses the bone marrow, and that is why patients who are on antithyroid medications have to have serial WBCs in order to look at or to monitor their WBCs and the development of anemia. Okay, let's now go to the other interventions other than medications to stop hyperthyroidism or to treat hyperthyroidism. And they include your radioactive iodine or surgical treatment. So let's take a look at radioactive iodine. So how is this done? Well, we actually destroy the thyroid gland over time, and it is going to be a permanent cure compared to medications. Unfortunately, this one is not going to be an ideal treatment for pregnant or nursing women. So it's only for non-pregnant and non-nursing women as far as radioactive iodine is concerned. And in the next slide, I'll discuss more about that. And the other treatment would be to remove the thyroid gland. So when we remove the thyroid gland, there's no more production of T3 and T4. But what does that mean, though? It means that the patient would have to be on long life therapy with Synthroid or your levothyroxine for life, because you now don't have any thyroid hormones. So let's go to radioactive iodine I-131. The thyroid gland, when given this medication, the radioactive iodine I-131, destroys the thyroid cells over a period of 6 to 8 weeks. And depending on the dose of the iodine chosen, what's going to happen is that the patient might be successful in having the thyroid gland killed or no longer going to secrete your thyroid hormones. So a major expected side effect of radioactive iodine is going to be lifelong hypothyroidism, and therefore the patient will require daily treatment with thyroid hormone. So there are several things that we have to make sure that we are going to do whenever we kill the thyroid. Because occasionally what's going to happen is that the thyroid is going to be destroyed, but it also could destroy the parathyroid gland. And therefore, we need to monitor the patient for signs of hypocalcemia. So what are the signs of hypocalcemia? The signs of hypocalcemia includes numbness and tingling of the toes and the extremities, as well as circumorally or around the lips. And it could also have what is known as Chostek signs and Trousseau sign. And Chostek sign is when you tap on the facial nerve and the face twitches. That's going to be your Chostek sign. And your Trousseau sign is carpopedal spasm when we tighten the brachia. So like, for example, if you take the blood pressure of the patient and the patient's hand begin to twitch or have spasms, that is going to be Trousseau sign. These are common questions in the Nclex, both Chostek sign and Trousseau sign, which are signs of hypocalcemia. Okay, so the treatment requires that the patient has to observe precautions for at least 7 days. So what are those precautions? This is the area that is going to be very frequently found in Nclex. Now, the reason why this patient has to obviously be isolated is because they are radioactive. And therefore, we're going to give them information in order to prevent them from contaminating others with radioactivity. So during the first 8 hours, what the instructions should include that the patient should drink 1 glass of water each hour. And the reason for that is you want to flush all the excess radioactive iodine, because you want the radioactive iodine only to be in the thyroid. So any excess has got to be eliminated. Now, whenever they are going to go to the bathroom, however, there's a risk for them to contaminate the toilet. And therefore, for men, what we have to tell them is they need to sit down to urinate. Women obviously sit down to urinate. So we emphasize the fact that they need to sit down, and this is going to reduce the possibility of splashing the urine. And therefore, if you splash the urine, then you're contaminating the toilet, obviously. And we're also going to ask them to use a tissue to wipe up any urine on the toilet bowl, and then they have to flush the toilet twice. Okay, so please remember all these precautions, because this is common in the Nclex. Okay, so hourly intake of fluid, and they're going to encourage them to void every hour for the first 8 hours. Then they have to maintain a distance of at least 3 feet from all people. And this follows the principles of exposure, that the farther you are from a radioactive source, the less radiation you're going to absorb. And therefore, this is something that we need to emphasize to them. And then, of course, we want to emphasize that they need to limit time in public places. So they should not be outside in the mall shopping, because they're going to contaminate people, at least for 3 days. And then, of course, if the patient is going to have to drive themselves, I mean, if they're not driving themselves, I should say, and they're riding with somebody right after the procedure, they must sit as far away from the driver as possible. The ideal thing would be for them to drive themselves. Okay, so no travel by airplane or public transportation in the first 3 days. And then, of course, they should not share cups, glasses, or eating utensils. And whenever they eat or use any utensils, they should wash the items promptly after using, so that others who are going to use those utensils are not going to be contaminated. During the first week also, make sure that the patient makes arrangements for others to take care of their children, and also to sleep alone for at least 7 days. Did I put that? Yeah, right there. Sleep in a separate bed or sleep alone. And when they eventually are going to what do you call that, sleep with somebody, they need to have a 6 feet separation from another for at least 11 days. They could not go back to work for at least 5 days. And we want to have a greater distance. You remember 3 feet for as a general rule, but 6 feet for pregnant women and children. And then, of course, as far as sex resumption is concerned, it's going to occur during the 7 days, or after 7 days, I should say. And they are supposed to use birth control because obviously, because of the radioactivity, it's possible that they are going to have abnormalities with fetal development. So this is in red. Do not become pregnant or father a child after radioactive iodine for 6 months for women and 2 months for men. Okay? So 6 months for women and 2 months for men. Okay, so what else? I think that's it. As far as the precautions are concerned. Oh, yeah. When people are going to the airport, when they are being checked, sometimes the radiation from the body may trigger radiation monitors, and therefore they have to make sure that they inform the airport personnel that they just had a radioactive iodine implanted. So these are some of the common precautions that need to be observed in patients with radioactive iodine. Okay, instead of lecturing on the side effects of radioactive iodine, I just wanted you to know that the side effects are going to include nausea, taste changes, dryness of the mouth, and swollen salivary glands. So it's not going to be excessive saliva, but rather dryness in the mouth. Okay, so we killed the thyroid gland with radioactive iodine. Now, we could also remove the thyroid gland. So if you remove the thyroid gland, obviously what's going to happen is that you're no longer going to produce your thyroid hormones. Now, there are several things or several implications of thyroidectomy. And the reason is the fact that the location of the surgery is very close to the respiratory tract and the trachea. Therefore, if there is this trachea right over here, which is neighboring your thyroid gland, and there's going to be inflammation as a result of trauma from the from the surgery, there's going to be a likelihood that you can compromise breathing. And therefore, it is important that tracheostomy, oxygen, suction at the bedside should always be prepared. And it doesn't have to be a tracheostomy. An endotracheal tray actually will suffice. Okay? But anyway, something to deal with the airway. And then the other thing is, you remember, as I said, that during surgery, when you hold the thyroid gland, what's going to happen is it's going to release a lot of the hormones. And therefore, thyrotoxicosis could be a manifestation that you will see post-operatively. So we have to monitor that. So the signs and symptoms of excessive hyperthyroidism is going to be noted as a complication. The other thing is bleeding. And in my practice, in my years of practice in the ICU, I really have a lot of experience in patients who have gone for thyroidectomy because this area is very vascular. So in addition to that, there's lots of blood that flows through the thyroid gland, and therefore bleeding is a potentially life-threatening complication. So you're going to have to observe for bleeding. And because the dressings are going to be on top right here. Bleeding doesn't necessarily have to be manifested on the dressing itself because they're lying down like this. So if they're lying down, what's going to happen to the blood if they bleed? It's going to go posteriorly. So whenever you are going to have a patient with thyroidectomy, you have to check the neck. You have to palpate the back to see if there's evidence of bleeding over there, because it might not show as saturated dressings. Okay, so that is very important. And of course, you always want to make sure that there are other signs of bleeding other than frank bleeding. The patient feeling tightness in the area means to say that there might be internal bleeding, and therefore it should be something that you have to be conscious about. You want to position them carefully. When a patient comes back from thyroidectomy, place them in a semi-Fowler's position. Now, sitting totally upright would put the patient at a 90-degree angle, but in a semi-Fowler's position, they're angled between 15 and 45 degrees, which means to say that there's going to be relaxation of that area. So semi-Fowler's position is better than a 90-degree angle. You don't want the patient to hyperextend their neck at all by bending it too much backwards, or having the patient drop their head or their chin to their chest, because that also puts a pressure onto the suture line. So you always want to keep the patient's head at the midline to avoid disrupting the suture line across their throat. Okay, now the neighbor of the thyroid gland behind it is actually our parathyroid gland. And therefore, what's going to happen is that they're going to possibly have an accidental removal of the parathyroid gland as well. And as we know, the parathyroid gland secrete parathyroid hormone, which increases calcium levels. And therefore, if the parathyroid glands are going to get damaged, they're not going to do their job, and calcium will not be increased, and therefore it will result in hypocalcemia. So we want to observe them for signs and symptoms of hypocalcemia, and we had already identified the two manifestations, which are Chostek sign and Trousseau sign. So again, Chostek sign is facial twitching when you tap the facial nerve, and Trousseau sign is when you encircle the brachial or put pressure on the arm, like taking a blood pressure. It results in carpopedal spasms. So this is going to be very important. And because of the fact that calcium might be too low, we have to make sure that we have calcium gluconate or calcium chloride at the bedside. This is a common question in Nclex. These two things, you have to have an airway equipment and calcium gluconate or calcium chloride at the bedside in order to deal with possible emergencies relating to the two. And then the other thing is that we need to make sure that we teach the patient to support the neck. So if they have to turn, we teach them to put their hands on each side of their face, and then they have to turn as a unit. Okay, so they can't twist their neck like this. If they turn, they have to turn the whole body. So in order to remind them, always make sure that you teach them to put their hands on each side of the face in order to protect them from twisting, which would cause bleeding of the site. And I tell you, when I hate thyroidectomies, post-thyroidectomy, because when they bleed, they really bleed. It's very vascular. So you don't want bleeding to happen at all. Now, the other thing that is a neighbor to the trachea is going to be the laryngeal nerve. So when we slice the neck, it is possible that the laryngeal nerve could be damaged. And that is the reason why you want to make sure that you evaluate the voice quality of the patient immediately post-op so that you can compare it during the immediate post-op period. Now, when there's worsening of the vocal quality, that means to say that the laryngeal nerve might have been damaged, and sometimes it might be just inflammation of the laryngeal nerve. So the way they treat that would be to give steroids. Obviously, if they have cut the laryngeal nerve, then there's going to be total cord paralysis, which would result in no voice at all, which is aphonia. Okay? We also evaluate their voice, because the voice quality, if it becomes less and less, it can not only be a manifestation of laryngeal nerve damage, but it could be as a result of squeezing into the vocal cords. So there might be internal bleeding. So again, voice quality is very important. You need to always assess the patient as far as their voice is concerned on an hourly basis. Those are very, very important thyroidectomy care, our patients with thyroidectomy that you have to observe. Okay, so just in the event that you are going to forget the signs and symptoms of hypocalcemia, remember CATS, convulsions, arrhythmias, tetany, spasms, and stridor. These are going to be manifestations of hypocalcemia. And then, of course, your Chostek sign is going to be your facial spasm, and your pedal spasm or your trousseau sign is going to be another one. But this is also another one, perineal sign, which we don't use that much. We use the brachial muscles to determine if there is carpopedal spasms. All right, so carpopedal spasms, cardiac dysrhythmias, dysphagia are other signs of severe calcium insufficiency, cramping, numbness and tingling, wheezing and dyspnea, and bronchospasm and laryngospasm. All these is going to be important, and that's the reason why you have to be prepared to treat severe hypocalcemia, because of bronchospasm and laryngospasm, which would lead to respiratory arrest. And then, of course, you could have seizures. As far as ECG is concerned, there's going to be prolongation of the QT interval. Okay, so over here it says 1 day post-thyroidectomy, what is most important for the RN? Range of motion to the neck that would cause bleeding, maintaining bed rest and supine position. Again, this is incorrect because it would provide pressure onto the incision. Ask questions every 1 to 2 hours to assess for hoarseness, and this is to assess for laryngeal nerve damage and also bleeding. Trach care. Patients who are going to be on thyroidectomy do not necessarily have tracheostomy. So this is incorrect. There's no tracheostomy necessary in patients with thyroidectomy. Yes, that is correct. Damage to the parathyroid glands. You remember, it causes hypocalcemia. Very good. And let's go to this one. All right, very good. Yes. This is what is known as Trousseau's sign when he has carpopedal spasms when the blood pressure is obtained. That is correct. Yes, the letter D is the correct response. Wonderful. You got that well. Uh, Oh, you're also smart. Okay, so the correct answer is letter C. They have to take thyroxine for the rest of their life. Okay, so let's go now to our case study. And this is our case study. This is a 32-year-old female with a history of hypothyroidism brought to the emergency room by their spouse. And at 9 o'clock, accompanied by the spouse, client reports being short of breath and having palpitations, placed in the ER treatment room directly from triage. Alert and oriented ×4, appears restless, anxious, and fatigued, has flashed skin that is hot to touch. Oh, okay, so it's hot to touch. Bilateral eye protrusion noted. Client states this is not their baseline and that their eyes feels very dry. Lung sounds clear, no reported cough, has intermittent and worsening dyspnea, S1, S2, 2 to 3 plus bilateral pulses, hyperactive bowel sounds. The client does not report any pain and states that they have felt excessive hunger and thirst over the past week that is unrelieved by oral intake. Also reports unexpectedly lost approximately 4 kilograms of body weight over the past week. Temperature 103 over 0.2. Pulse is 137. Blood pressure 152 over 98. And pulse oximeter is up 97% and pain is 0. All right. So let's go now to the question. And the question is, what four findings are going to be most urgent? And you have a poll with that one. So we're only looking for 4. Okay, so let's see. Would you be worried about her dyspnea? Obviously, I would be, right? So this is okay. Now, the 2 to 3 pulse grade is normal, so that this is not going to be significant. But the tachycardia, I'm worried because it actually is a manifestation of your increase in thyroid hormones as well as palpitations. Hunger, thirst, that is going to be also okay, but not as critical as the fever, I think. So these are the 4 things that are going to be correct. All the client findings are concerning. Yes, true. But the physiological findings of dyspnea, tachycardia, palpitations, and fever are the most important ones compared to the other ones. Okay? So that would be the way in which to answer that question. All right. So it's the same information, but now we're being asked a question. And the question is, for each assessment the nurse has made, click to specify whether the finding is helpful or not in determining if the client is experiencing a thyroid problem. So in your question, it's just going to be if it is helpful. You're all correct because fever, bilateral eye protrusion, anxiety, palpitations, and dyspnea are all going to be very helpful in determining if the client is experiencing a thyroid problem. So we all know that those are related to metabolic activity. Okay, so question number 3. So it's the same information. And the question is, the nurse is going to recognize that the client is most likely experiencing what? Okay, very good. You all got that correctly. The client's manifestations show that she is hypermetabolic, and therefore this is going to be a manifestation of thyroid storm. Okay, and question number 4, which of the following orders should the nurse anticipate? So it's still the same information, but we're now going to look at the orders, a list of orders, and check whether or not they're appropriate. Okay, you're all very good. Everything here is going to be appropriate except for the administration of as aspirin. And so I wanted to just make sure that you know this, that anytime you give aspirin to a patient with thyroid disorders, it increases thyroid hormone. And therefore, we don't want to give aspirin products to these patients. So none of you selected that, which is very, very good. Okay. So the nurse reviews the client's vital signs and the provider's orders. Choose two orders that the nurse should implement first. So you're going to choose only two. Okay, so when you are actually working and you have this person, right? And you have all these orders. So you need to know how to prioritize. So always think about ABC, airway, breathing, circulation. So over here, the breathing is going to be the 2 liters of humidified oxygen, right? And circulation would be the 12 lead ECG, because you remember with this hypermetabolic state, the patient is most likely to have arrhythmias. All the others are going to come. Like, for example, this one, you have to start an IV if you don't have an IV yet. And then, of course, you could always do these later as well. This would be the last one because nobody dies from not having the artificial eyes. Okay? So always remember again A, B, and C. And let's take up the last one. The nurse, the nurse administered the client's oral acetaminophen and methimazole and placed the client on oxygen and institutes cooling measures. The nurse reviews the laboratory report and reassesses the client. For each finding, click to specify if the finding indicates that the client's status is improved or remains unchanged. Okay, so let's take a look at the temperature. The temperature originally was 103, and now it is 102. So I guess this is an improvement. How about the anxiety level? Client observed sitting up on stretcher, remains alert and cooperative, but still very anxious. That is the latest at 11 o'clock. So that means to say that this is unchanged. How about the respiratory rate? 28, and now what? Oh, this is 26, not 226, and then 24. So I guess this is an improvement, isn't it? And the heart rate, where is the heart rate? Right there. 137, and now it's 127. That is improving as well. And how about the oxygenation? 97%. 97%, it's still the same. So it's unchanged. And the pain level, it remains 0, and that is unchanged. So, ladies, it has been my pleasure being with you for 9 days. And I do hope, it is my hope that you're going to be successful in the Nclex. And I wish you all the luck in the world. Please keep in touch with me and let me know if you have any questions or how you did in the Nclex for that matter. My email is displayed right there, tmadayag@broward.edu. So I wish you all the luck. I'll be praying for all of you. Thank you.
I have a question.
Yeah, go ahead.
Okay, so I'm kind of confused on when it comes with the thyroid storm and the temperature. So
Yeah.
if they come in with like a high temperature of like 104, 105.
It probably would be higher than that, to tell you the truth. Yeah.
Right. Do you get their fever down first, or what?
ABC. So it's going to be airway, breathing, and then deal with the circulation last. So that would be under C.
Okay.
Yeah,
so
always remember that. Maslow's hierarchy and the ABC and nursing process. So whenever you are dealing with which one is the priority, think about Maslow, think about ABC, and then Maslow, because physiologic needs occur, has more importance than your emotional needs, right? And ABC would be the criteria for dealing with physiological basis of how we approach things. And then nursing wise, always remember, don't implement something until you have assessed a patient. So
Right.
assessment first before implementation.
Okay, so an example, like if they came in without nothing wrong with airway or breathing, you would go to
Circulation.
Okay, I was
Correct.
just making okay.
Yeah. Or even Maslow, depending again on the question. So you
Right.
can apply those 3 things, right? So if
Okay.
it's physiologic needs first, if the patient is nervous, she will not die from nervousness. But applying Maslow's hierarchy, look for the physiologic need. Like, for example, if the patient has fever and nervousness, you have to deal with the fever first, because that's a physiologic need, and then go to the emotional need.
Right.
Yeah.
Got it. Thank you.
You are welcome. All right. Good luck to everyone.
Thank you. Will these recordings be available?
Yes, it is in my YouTube channel. So go back to the to my YouTube channel. It's Tom Madayag, and I had posted everything that we had done last week. I don't, including the one that we did on Tuesday, but not yesterday and today. So the one yesterday and today will be posted probably tomorrow.
Okay, thank you so much.
You're welcome. Good luck, okay?
Thank you.
Yes, you're
Thank you.
welcome. You're welcome.